ECG testing can be done with 3, 4, or 5 electrode systems, all of which are grounded to block the patient from being electrically shocked by the equipment. Today, you will likely encounter 3 lead wire, 5 lead wire, and telemetry monitoring systems. When working with the 3 and 5 lead wire apparatus, you may encounter electrode positions for one lead that are identical to another. Simply change the lead selector to the appropriate corresponding lead. You might have to reposition the electrodes when this situation occurs. Leads allow us different views of the heart. It is somewhat like adjusting the angle of your camera. The view for lead 1 shows current moving from the right to left, from the negative to the positive. So the positive electrode for lead 1 is placed on the left arm or the left side of the chest. The negative electrode is placed on the right arm. The third electrode is a ground. This minimizes electrical activity from other sources. Lead 1 produces a positive deflection on ECG tracings and is helpful in monitoring atrial rhythms and hemiblocks. Lead 2, one of the most commonly used leads, also produces positive deflection. The positive electrode is placed on the patient's left leg and the negative electrode on the right arm. When a leg placement is indicated, that means to place the lead on the torso above the waist, not actually on the leg. Place the positive electrode below the lowest palpable rib at the left midclavicular line and the negative electrode below the right clavicle. In this lead, the current travels down and to the left following the normal conduction system of the heart. Lead 2 gives us information about the inferior wall of the heart. It is also useful for detecting sinus node and atrial arrhythmias and for routine monitoring. Lead 3 also produces a positive deflection, so the positive electrode is placed on the left leg, the negative electrode on the left arm. Along with lead 2, this helps detect changes associated with an inferior wall myocardial infarction. The access leads 1, 2, and 3 form a triangle around the heart and provide a frontal plane view of the heart.
The modified chest lead, MCL1, looks at the anterior wall of the heart. It can be used to best assess QRS complex arrhythmias. The negative electrode is placed on the left upper chest, the positive electrode on the right side of the sternum at the 4th intercostal space, and the ground electrode usually on the right upper chest. Use the MCL1 to monitor premature ventricular beats and to distinguish types of tachycardia, ventricular and supraventricular. It can also be used to assess bundle branch defects and P wave changes and to confirm pacemaker wire placement. It is important to note that the QRS in MCL1 can be negative and still be normal. Remember, lead views need to be chosen to reflect the need. If a patient has an anterior MI, you would want to look at the modified chest lead. If the patient had an inferior wall MI, then you would want to use lead 2. Also, be sure your gain is adjusted properly. Tall, pointy P or T waves could mean the gain is too high. Narrow, flattened waves could be a result of a gain set too low.